Good morning, everyone. How's West High School doing these days? You guys ready to go back to school? Is it fun? You have a good break? My name is Hope Helfrich, and I am the Clinical Affiliations Coordinator for Wesley Medical Center, so that means I take care of students that come to Wesley. I'm an RN and just celebrated 35 years this week as an employee. Congratulations. And I'm just excited to have this opportunity, and I want to thank you guys for joining us and Ms. Robinson for doing her part, because it does take a small village here to produce this production. So thank you for participating. I sent an evaluation tool to Ms. Robinson early this morning, but she may have already distributed one to you, and that is critical that we have you return that to us if you've got a chance to answer those questions. We have seen your questions, and the speakers are going to incorporate some of those questions into their talk, but there may be some questions that we don't answer just because of time, or we have some new questions that pop up. So we'll be glad to take those questions at the end as time allows. Again, thank you all for joining us, and I want to introduce our two presenters today. Next to me is Melanie Asmussen. She is the manager of our respiratory care department, and so she is intimately involved in all the care of the critical patients that are here at Wesley. And then joining us from a remote distance is Michael Lowe. He is the manager of our medical intensive care unit, which is where we have housed many of our COVID positive patients that need that deeper, more intensive level of care. And they're going to take you through some of their responsibilities, what kind of care is done, and try to answer those questions that we submitted. So I think I'll turn it over to those two. See you guys in a bit.
Hey, good morning, welcome. I will go first. My name is Mel Asmussen. I am the manager of respiratory care. Many people don't even know what a respiratory therapist does until probably the pandemic happened. I am a registered respiratory therapist, and I'm credentialed with the National Board of Respiratory Care. I actually went to school in many years ago, and the school does no longer exist. But there are several respiratory schools out and about in the region. To get into school, it is an associate's degree primarily. Most of the schools in the region do offer that associate's. There is one bachelor's program in the state, and that's at KU. I have actually been working 26 out of 28 years in my career in a hospital. This is where I was raised, and this is my home. It's inside of a hospital. What got me interested into respiratory care, I think Fatima had this question, was I was actually sitting in your desk as a senior, and I was required to do volunteer hours. And with those volunteer hours, I chose a hospital. And they placed me in a respiratory care department. I didn't even know what respiratory care was when I was 18 years old. And they placed me in the department. I started doing some volunteer hours. When I graduated, a position opened up as a unit clerk. I was introduced to hospital life, and it got me interested in health and knowing what a respiratory therapist does. I was in college. I didn't know what I wanted to do, and that's okay. I was just kind of trying to get my prerequisites and try and figure out what I wanted to do. And then I chose to get into respiratory care school. It's about a 2-year program, and I have worked my way up since then in different positions in the hospital, and I'm currently the manager here at Wesley. Michael, do you want to go next?
Sure. Like Hope said, my name is Michael Lowe. I am the manager at the medical intensive ICU, in the medical intensive care unit. And like she also said, yes, we've primarily been the unit that's housing patients that are needing care for COVID. I started at Wesley, it's just under 7 years ago. And nursing was actually a second career for me. I came to nursing in my early 30s. And one of these questions that I think Denari asked was, no, I'm sorry. Yeah, Denari, if you could redo your life, would you choose the same job? The answer to that would be yes. If I could redo my life, I would have started nursing in my first career, because there's just so much about it that I love. I won't take the whole time talking about it, but it's a fantastic career. And being in the MICU is kind of new-ish to me. I started in the surgical ICU when I came to Wesley 7 years ago, and as just a bedside nurse on night shift, learning the ropes. And there's a lot to learn, especially working in ICU in a huge hospital like Wesley. We take care of all sorts of very, very sick patients, and a lot of patients that just need a little help for a day or two to get on their way back home. But there's lots of opportunity in any unit that you work in: respiratory therapy, nursing, lots of awesome career options. And so SICU for 5 years, moved up to MICU as the manager a couple years ago, and I had absolutely no idea, nor did anyone, that COVID would be coming our way just about 8 months after I started. And well, it's really turned our world upside down, not just ours, but not just ours in the healthcare world, but everyone across the globe. I'm sure that all of your families have been impacted in one way or another, and we're all learning how to deal with it. So I know that you all are still students and we're in the healthcare world, but trust me, we're all feeling the stress of this, and it impacts us whether or not we're dealing with COVID patients and being on the front lines. So yeah, should we dive into some of these questions, Mel?
Okay, sounds good. One of the questions that Kayla and Fatima both asked, which is a fantastic question, is what is a respiratory therapist? That's a really good question, because most of the world didn't really know what a respiratory therapist was until COVID, and they probably still don't.
I'm still trying to figure it out.
A respiratory therapist is pretty much anyone that specializes in treating anything that has to do with lungs. So I'm standing here with a ventilator. A ventilator, otherwise known as life support, otherwise known as a breathing machine. This is one of the many things that we do on all patients and COVID patients. To kind of back up, anyone that's asthma comes in with having COPD or emphysema, having breathing problems, pneumonia, any of those patients that need any kind of breathing treatments or ventilatory support, that's when we get called. We are different than nursing in the fact that we go every place a patient goes. So I could be working the ER today, and I could be working MICU tomorrow, and be working in the neonatal intensive care unit the next day. So we are very diverse, and we take care of all age populations, from all the way to helping to deliver a baby that's being born premature, all the way to intubating and placing a patient on a ventilator, and attending a code blue where we're doing CPR at end of life. One of the other questions Kayla asked was, what is the maximum amount of oxygen someone can be on? And that's kind of a little bit of a loaded question, but the oxygen, room air, what you and I are breathing right now, is 21%. That's what's in the atmosphere, and you can never go below 21%. We can go all the way up to 100%. Now, there's other things that we can do, like the ventilator, where it comes in with pressures and flows and volumes and all that sciencey stuff, where we can kind of push oxygen in and help increase that. But to answer the actual question, oxygen can be 21 to 100%. Michael, do you want to take a couple?
Yeah. Let's see. I apologize if I'm mispronouncing this, but I think Sincere asked the question, what is it about critical care nursing that made you want to choose this profession? Well, a couple things there. when I was in nursing school, I wasn't 100% sure what type of nursing I wanted to do. All I knew was that nursing was a profession I was headed for. And if any of you are planning on going to nursing school, you will see that there's just an endless array of different type of specialties that are open to you. So it's kind of tough to choose unless you really know what you want. I ended up in critical care from following some of the nurses during my training and shadowing them and seeing what the job was like in critical care. And the thing that attracted me the most about it was the critical thinking element. In nursing and in healthcare, we all have these protocols and guidelines, evidence-based best practice that are standardized and you have to follow. And there's just a mountain of those that you need to be familiar with. But in critical care, there's a much more complicated piece, and that's just kind of the art of critical care nursing and of really any type of nursing. But it's the critical thinking piece where you have to have that body of knowledge and be aware of all those protocols and evidence and find a way to pick out from all of those and put together the picture and the plan that makes the most sense for your patient and what they need at that moment. And it changes from moment to moment to moment. And just that, I'm one who kind of an adrenaline junkie and like just thrives on not knowing what to do and finding a way to figure it out. And that piece of critical care nursing is what just kind of turned me into a junkie for it. I know that I'm not at the bedside anymore. I'm in management now, but it's still critical care. I know that whatever type of role I'm in, it'll always have to do something with critical care, just because of that passion I have for it.
Michael and I agree. I think RTs are the adrenaline junkies too, and critical cares are both favorite parts. Like I said, with code blues and deliveries and traumas and ventilators and thinking outside the box and coming up with solutions with our care team, because we partner with you and the physicians tremendously to figure out how to put the puzzle together that best fits and take care of the patient. I've got a question from I'm going to try and pronounce this correctly, Kayla. What does RT do with COVID patients, and is your job different now that COVID is around? At the end of the day, our jobs really aren't different in the fact that we're still taking the same care of the patient with the same pieces of equipment. We just have to kind of think a little bit differently to figure out how we can best tackle COVID and take care of the patient. What we do with patients is, for the most part, and I know some of you have had a lot of direct experience with COVID, every case with COVID presents a little bit differently in the fact that some people will come into the ED and they can get dismissed and go home, and that's fantastic. Others, they need extra oxygen or they need fluids, and so those are some of the things that they might get admitted and be placed into a regular or a med-surg bed. And then we work with them and try and improve those things. If their oxygen levels and whatnot continue to deteriorate, that's when we call Michael and his team, and the patient will likely get moved over to the ICU. And then we try to do everything we can by doing different things so that we don't have to put them on this thing. One of the biggest things that we've done differently, and it's primarily been my team and Michael's team, is we're proning people now very routinely, because we never did that a whole lot, and now most of our COVID patients are proning. Proning is putting a patient on their tummy and spending 16 to 20 hours a day on their tummy, and it's best if they do it. Even if you're sick with COVID, you can lay on your stomach to help improve oxygenation. But what it does is it helps improve oxygenation and kind of moves things around as a proactive way so that we don't have to go to death. Sometimes we do, and we will still put people on this breathing machine with a tube down their throat, and we will still turn them on their tummies. And it takes about 6 or 7 people to do that. Can you hold this for me? One of the questions with that is, how do we protect ourselves from the virus? as all 7 of us are sitting there trying to flip a patient that is sedated on their tummy, we are wearing our PPE. And our PPE, to protect ourselves, we have an N95 mask. This is an N95 mask, so that way the air is more filtered in. This is called a duck bill, quack, quack. And then we have a face shield, so that way our eyes are, I'm going to get a little bit closer, so our eyes are protected. But now you can see how muffled it is. And then we put on a gown over our clothes, which I have. I put on a gown, kind of like wearing a trash bag, so to speak. And then there's 7 of us around a bed. One person's at the head, and we coordinate our efforts to take a patient and flip them over. And so you're looking at patients that are 200 pounds. Think about your moms and your dads, that we are all collectively flipping while keeping this thing connected with all of Michael's IVs and tubes and everything, because we want to protect the patient. So, and the last thing to kind of talk about with COVID is one of the questions, forgive me, I don't remember who it was, said, what do we do? We're doing the same things in the hospital that we're asking you to do at home to protect yourself. Wear a mask, social distance, a lot of good hand hygiene, and those are the 3 things that are definitely the most important, because I truly believe us caregivers in the hospital, this is one of the safest places for us, because we do have our PPE and we are wearing masks and we have our protection, and so that we can be here to take care of the patients. So I'm going to doff my PPE, which is take it off. So I'm going to turn it over to Michael to talk for a little bit.
There was a question kind of along the same lines as the one that you just addressed there, Mel. Kayla asked, when a patient is in the ICU due to COVID-19, what's being done to help better the patient? Mel just answered a lot of those questions as far as respiratory wise. I will say, as far as on the medical side, and nursing interventions, what can be done, most of it, in fact, is the things that Mel mentioned. The trickiest thing, and maybe the scariest thing about this virus, is, as with most, and if not all viruses, there's never really a cure. Yes, we have some medications like remdesivir, which you've probably heard in the news or wherever else, that are antiviral medications, and there's some therapeutic medications to help with the way that the virus affects your body. But we don't have any medication that directly attacks the virus to help get rid of it. So most of what we do as doctors and nurses and respiratory therapists and as a team is just do everything we can to investigate how the virus is impacting the body and implement as many interventions as we can to mediate and improve those specific areas. And a lot of it is just kind of playing whack-a-mole, because it affects everyone so differently. And unfortunately, with diseases like this, it's almost a game of cross your fingers and hope, because we never know. We never know how one person is going to do from the next. I mean, it's so unpredictable across the board. Like, you might see one patient come in who's elderly and do fine, another patient who comes in who's otherwise young and healthy, and it just totally devastates, their state of health. So to that question, what's being done to help better the patient? Anything and everything. It's a new disease. It's a new virus that we don't know that much about, despite it having been with us for, oh gosh, it's almost been a year now. Whew. And we're just learning as we go.
Michael, could I ask you a question?
Sure.
Yes.
So I think my students would also be interested to know, we pretty much all understand the respiratory What? Excuse me. I'm so sorry. I am recovering from COVID myself. We pretty much understand the respiratory problems that exist with COVID. Can you speak to some of the other complications that can occur, like in other systems of the body that you have seen,
Hmm.
like either cardiac or urinary or other systems that have been affected? Have you seen other systems?
Yeah. So the one that's the most common, and uh, I wish I had my ICU intensivist here to speak to more of what the pathophysiology and the mechanism is about the virus that causes this, but it just wreaks havoc on a lot of people's clotting factors. Um, in your when your body makes blood clots to help heal, and there's a very complicated process that goes through. I won't get into that, but basically something about COVID in certain people, there may be a genetic component. We're not sure, but it just sends that clotting cascade totally haywire to where sometimes your body's making little tiny clots all over for no reason, sometimes big clots, and sometimes it makes it to where your blood won't clot and you're just bleed all the time. Like some people, if you're a hemophiliac and you bleed, it just causes all sorts of different problems with the clotting cascade. And so that can really impact anything and everything in your body, depending on where clots do or don't form. For example, if you get a bunch of clots in your leg and then you stand up and those clots bust loose, then they're going to travel up your veins and end up in your lungs. And then that can cause significant damage to your lungs, in addition to what COVID's already doing there. If they end up somewhere else, like in your neck, your blood could break them through and then it ends up in your brain and ends up with a stroke. So that's not common by any means. It feels common to me because I work in the ICU and I see these COVID patients who are the most sick. By and large, this is not happening to the majority of people. But when COVID is really, really bad in someone, we have to watch their clotting factors really closely. There's a lot of lab work that we draw to monitor, and there's things we can do to prevent that. If we see that someone's clotting factors are elevated, we can give medications to help thin the blood, and vice versa. If they're very low on platelets, then we can give platelets just like we give blood to help balance those, based on the lab work and how the patient presents.
And one other thing that I wanted to add to is something that we're starting to see, and I've even seen it in some of my people that I know personally that have had COVID, is an inflammatory response. Everyone knows about the respiratory, but there's a big inflammatory component that is probably in between that, almost everyone has a respiratory response. And really only the sickest of the sick have what Michael described with the clotting factors and having strokes and pulmonary embolisms and those kind of things because of the clots. But we're starting to see more and more people have inflammatory problems, whether it be with their, they have ongoing trouble catching their breath for months on end, or they have heart problems where they have to have cardiac tests for months afterwards. And so that's really the piece that, we just don't know a whole lot about. And that's, I think Alexis had asked, what is the most difficult part of your job, at least right now, with COVID and with my team and Michael's team, is some of us, we will see COVID and it's kind of like, it's a roller coaster where they get better and then they get worse. And we think we're kind of over the hump of COVID. And then something happens that throws us for a loop, like a stroke or a pulmonary embolism. And it just kind of turns us upside down, and it kind of takes the wind out of our sails. Goes like, oh, we put all this blood and heartache and tears into this patient trying to get them better, and they look like they were better, and then something happens. And it's hard, and it's defeating, and it's tough. And there's a lot of times where we go home and we're crying on the way home because we lost somebody, because we are working hard to save them. And it's of those things that, okay, I've got to put on my scrubs again the next day and take care of somebody else and see what I can learn to do better. So does that help with answering that question? Melody, is there any other questions that your students have that we haven't addressed or that we've opened up that weren't sent to us?
Well, Kayla, you hear me? Yes. Okay.
Yeah.
Kayla asked, I understand when you say that every case is different because my grandpa just passed away, but he did have other medical issues, but his organs started failing. And 2 weeks later, my uncle passed away. Even though they said they were going to take him off the ventilator because he was doing better, but the next day his heart gave out. He did not have other medical issues. So I think we have a lot of students who have, who have experienced this with friends and family, that they think things are going okay and then something happens. So that's one reason I wanted you to kind of speak to the unusualness. This is not the flu. This is definitely not the flu. This is something that we are all learning about as we're going along. And Mike, as you said, it's almost a year now, and yet there's still so many new things that are happening and learning about this disease. So I know it has totally affected the way you have to handle your job and your job description, I would think. Now, Mike, can I ask you a question? If you are looking, say, at your MICU, say in the last 3 months, how many COVID patients versus how many like heart attacks, just regular heart attacks, strokes, something that has nothing to do with COVID? Is your unit, say, 2/3 COVID? Have you got it separated out? Or is like your COVID unit over here and your other complicated patients over on this side? How have you done that?
My unit has been 100% COVID for several months now.
Okay.
Yeah, we have 4 ICUs at Wesley, so we've been able to segregate our ICU as the COVID ICU. I believe it was like September through October through November where our numbers got so great that we had to isolate another section of another ICU as an overflow, essentially. And there's actually a fantastic website, Sedgwick County. I just Google Sedgwick County COVID. They have a dashboard that shows the numbers of COVID patients in Wichita in the ICUs. And if you look at that, you can see how many are full, and it's been at 100% since last I looked. And yeah, we're still at 100% COVID in the medical ICU today. With a few, we do have more COVID patients than what are in my ICU, but in the other ICUs, what we're doing now is after 20 days, patients who have had COVID, they can be downgraded out of the precautions because they're no longer considered to be infectious. It's somewhere between 10 and 20 days. We know that 20 days is the safest point to where we don't have to take as great precautions because they won't be spreaders anymore. So we've tried to take those patients out to a different ICU where they're no longer at risk of affecting other patients that are in the hospital, and dedicating MICU to the patients at the highest risk of still being infectious. But yes, it is definitely not a workflow that we're used to.
Yes.
And Melody, there was, you made a comment about there's so much we don't know. That kind of coincides. One of the questions had to do with a question about the vaccine, I think Perla asked. That's another thing that we really don't know a whole lot. Never have we ever, like my kids would say, ever had a vaccine created and distributed within a year. And so it's definitely a light in the middle of our tunnel. It's fantastic for us here. That definitely helped give us a boost of positivity here in the hospital, that we're like, okay, there's a light, and we didn't have, many of us got that, and we've already started our second doses. There's a lot of people that haven't taken it yet because of their physicians They don't know what the long-term effects are, specifically like pregnancy and if they're lactating or something like that. And so over the next 5 years, as you all are graduating and going into college and entering the health field, if that's what you want to do, there is going to be a huge amount of change in healthcare. And as more and more studies are happening, the way we've done healthcare the last 20 years is probably not going to be the way we do healthcare in the next 20 years. And so you guys are seeing history and you're seeing it turn, and just it's really it's going to be exciting to see what advances and what we learn from COVID and how we can do our jobs better so that we can take care of patients better in the future. I'm going to start off with a story and then if Michael can maybe add to it. Everyone talks about the bad stuff of COVID. We've had, and maybe you've seen it on the news, we've had 2 different patients let me back up. In healthcare, there is so much bad stuff or negativity with patients. So that's why it's really important, more now than ever, to celebrate the good, celebrate the win. And so we've had a couple of patients that were on our service. They were on the ventilator for weeks. They were in Michael's unit for weeks, and they had COVID. There were days where we didn't think that they were going to make it through the next shift or the next day. And there's 2 particular cases that I can think of that they left. There was one, he was here for, I think, 93 days. He was admitted at the end of July, 1st of August, and he just went home about a month or so ago. Is that right, Michael? Maybe? Yeah. Mm-hmm. He got pushed out on a wheelchair. We're all in line in the hallway, and we're clapping and rooting him on, and he's smiling. And it's the first time he's seen the outside of the hospital in like 93 days. That gives you chills. So one of the best ones that I think it encompassed the entire hospital. We had a mom that was admitted in April that was 24 weeks pregnant, and she had COVID. She was in Michael's unit. She was super sick. She was on the ventilator for weeks. We had labor and delivery on standby. We had the delivery team on standby. We had surgery on standby because we not only had to take care of mom, but we had a baby to take care of too. And we were ready to take that baby at any time to protect the baby. She came back, and I think it was like June. She came back, and she had a healthy, bouncing baby boy. He would have big old heavy cheeks and looked like a little wrestler. But she went out on her with her wheelchair, holding her baby, and went back home. And again, that's why we do what we do. So, Michael, do you have anything to add to those 2 stories? Because you know them a little bit better.
I honestly could talk about those 2 stories all the rest of the day, because they are those bright shining lights. There's a couple of questions kind of along the same lines that I was going to combine into one answer. One from Markayla and Sincere. This is, what are the pressures of working at MICU? How do you handle them? And down under the COVID questions, from Perla, how has COVID-19 affected MICU? And from Denari, is it hard at times? Do you feel overwhelmed? And then as well from Sincere, how do you establish good relationships with the patients and the family members? So all those questions kind of combine into what's been the hardest thing about what we've been doing these last several months, and that is the isolation. Healthcare at its core, like foundational, is about like a human connection and just the innate desire to help one another. And we have a lot of medicine and science that we use to do that, but without that human connection and human touch, people don't do as well. And we know that, and we know that from science as well, actually. And the ability to see family members and connect is such a powerful healing force when anyone's sick, whether it's COVID or whatever else. And the way this virus has forced us to not allow family members into the hospital, not allow loved ones, and even as nurses, we can't go in the rooms without all the garb that Mel showed you that we have to wear. They can't see our faces. They can't see our expressions when we're trying to care for them and tell them that we're here to help. And it causes a lot of anxiety, fear, and stress, which makes the body harder to heal. Not only for the patient, but it makes us nurses more and more exhausted. It makes everyone involved in the healthcare profession. It's exhausting and it's hard. And we've had to watch so much pain and suffering from not only from the patients, but from these family members who our heart is just breaking for, because we have to tell them day after day that they can't come and see their loved ones, at least not for 20 days, until we can finally get them out of restrictions. And then one person is allowed to come see them at the bedside. And it's just heart-wrenching. And I'm sure that some of you in this class have had to experience that. And with not being able to go see a friend or a loved one in a hospital. And that's been the hardest part for me and for my nurses, I know. Yes, we've seen a lot of people pass away. But what makes that harder is having to care for them through those days, talking to their wives, husbands, children, and updating them over the phone. And then when they pass, trying to accommodate some way to visit, because we're just so desperate to let them have that connection again. And it's just been really tough. I see we're almost at end of our time. I didn't mean to end on a down note, but just know that we are all working our hardest, not only in the healthcare profession, but everyone is just doing their best to try to get through this. And we will. And more of those happy stories that Mel mentioned, we're going to see more and more of those as we know more about the disease and as we all protect ourselves and get through this crazy thing.
I think the last number I heard is we've cared for over 800 patients with COVID that went home. So again, focus on the good, focus on the wins. That's 800 people that we took care of that got to go back to their homes and their families. Melody, how are we doing on time for you?
We haven't actually until 9:20. I know it's kind of was set for 9 o'clock as being the end, but could I ask one more quick question of you, Mel? So with COVID, do you think the number of respiratory therapy job opportunities have increased? You know, I'm just thinking about, say, a year ago, how many job opportunities for respiratory therapy as compared to today? Because I think it's a job that a lot of kids aren't really thinking about. They think about nursing and they think about, maybe phlebotomy or EKG tech or we have those opportunities. My kids, as going into seniors, are getting ready to choose whether to do EMT, CNA, phlebotomy, EKG through WSU Tech next year. WSU Tech doesn't have a respiratory therapy program, but I know Newman does. And I'm not sure the other places that do, but I'm just wondering, is this a job that has just exploded?
Yes, and I love that question, actually. I think because of what you said, so many people don't even know what respiratory therapist is, or even that it exists. That's definitely an opportunity now more than ever. It is a huge demand for respiratory therapists. So if you are looking at, where can I have a secure employment for the next 10, 20, 30 years, it's going to be healthcare, but respiratory therapists right now is booming, especially now with COVID. The amount of devices that we are running with all of our respiratory patients, it has changed our profession a lot, and we are at the bedside so much more taking care of these people. From the respiratory therapist standpoint, you can really get your prerequisites anywhere, whatever best suits what you're liking for a school. There's, I think, 7 respiratory therapist schools in the region. You mentioned Newman University. There's one at Hutch Community College, which isn't too far away. and we do clinicals for both of them. We also do clinicals for Labette Community College in Labette County. We do clinicals for Stewart Community College, which is down in Liberal. There's a school in Washburn. There's one at KU. There's a couple of others up in the Kansas City area. So there's definitely different school choices. It is a program that you have to apply to get into that program. And it's your basic prerequisites of chemistry, college algebra, English, so on and so forth. But what that does is get your prerequisites. If you are interested in respiratory therapy, reach out to me, and you can reach out to Hope, and she can give you my contact information. If you want more individual specific questions, I'm happy to do that. And then apply to the program. During your program, you have your didactic work, learning the pressures and the volumes and all that kind of stuff. But then the most important part really is your clinical experience, where you actually come into the hospital. And yes, we are still doing clinicals for people to come in and they have hands-on exposure with patients, and they get to go to different hospitals to see how different people do that with a preceptor, and then you can graduate and find a position. Respiratory therapist, like I said, there is the critical care aspect, but there's not a whole lot of positions in the hospital that can attend a delivery and go into the neonatal intensive care, go down and do a level 1 trauma in the ER, and go do compressions in a code blue up on the tower. And yes, I'm an adrenaline junkie. I can do all of those in the same day, in the same shift even. And we even have some respiratory therapists that will fly. They do neonatal transport, and they are working here. They go to a delivery, and they'll fly out to Midland to go pick up a baby today. So lots of different opportunities and fluctuations and so on and so forth, and tons of experience and exposure. So is there any other questions? Because I think we've got a little bit more time. We can either go back to some of the printed questions we skipped, or if you guys have some questions.
I was checking my to see if anyone else had any other questions.
Okay.
I don't see any in the chat unless there are other questions that you guys had on your list. I know my students sent some really good questions. They were very thought-provoking, I thought, this time. But I can't tell you guys how much we appreciate that. Yeah, we've got about 10 minutes before the bell rings, but I'm okay. Whatever works for you guys. If you guys need to leave, or if you got some other time to answer other questions, that's great. Mike, also, I thought you might speak to the idea that a unit such as an MICU or SICU, CCU unit, how those units are different from, say, the tower units, the more one-on-one nursing, could you sort of speak to what makes your unit different than just a regular room?
Yeah, oh yeah, they're very, very different. So in any hospital, in the traditional hospital setup, there's the acute care side and there's the ICU side. Acute care is what most people think of a regular hospital room. If you go to the hospital, you're sick enough to be admitted, you're going to go to the acute care. The way those are set up, most nurses have it, depending on the type of unit and the care that's provided there, anywhere from like 4 to 6 patients per nurse. So the nursing there is, and they also have aides to help with a lot of the routine cares, like up and down to the bathroom, meals and stuff like that. Whereas the nursing role over there is mostly doing your assessments of the patient once the shift, making sure everything hopefully looks good or the same or improving, or identifying changes that need to be addressed, and then moving on to the next patient. When you have 6 patients, you can't really spend a whole lot of time in any one room during your shift. You got to really keep moving. In the ICU, you also have to keep moving all the time, but it's very different. I mean, when you're a patient in the ICU, you're sick enough to require a very high level of monitoring. That's not to say that everyone in the ICU is like on the verge of death or by any stretch of the imagination, but whatever's going on with that patient requires a nurse at the bedside pretty much around the clock to be looking at your EKG, your oxygen levels, your respiratory rate. And the nurses in the ICU typically have two patients. There's some patients who are sick enough where they have one nurse dedicated just to that patient, and sometimes even patients who have two nurses dedicated to that one patient 24 hours a day. The example that Mel gave with the pregnant woman who came in over the summer, we had two nurses at bedside around the clock with that woman. One was from the labor and delivery, and one adult ICU nurse monitoring both mother and baby. So nursing is nursing. It's the same nursing thought process, but the way that process is delivered just looks a little bit different in those units. The workflow is incredibly different. I'll tell you the truth. I'm an ICU nurse. If you tried to put me in an acute care unit, I would have no idea what I was doing, because it's such a different thought process. It might be easy to think that us as ICU nurses require more training, more skill, more knowledge. That's not true whatsoever. It's just a lot of different skills and different knowledges, where in the acute care side, there's just as much to learn, but it's a different art and different skill and different workflow. And that's going back to one of the earlier questions. It's one of the things I love most about nursing is anywhere you go, it's like a whole different job, a whole different profession. It's still nursing, but whatever specialty area you're in is wildly different than wherever you might go on another day.
It's kind of like teaching. A high school teacher is still and an elementary teacher. They're both teachers, but their days look incredibly different. So thank you so much for coming to visit with Michael and I, and I'm going to turn it over to Ms. Hope and take it away.
I appreciate you guys. You've been very attentive and you've asked wonderful questions. So as we kind of wrap this up, I would ask two things. If you have additional questions, get a hold of Miss Melody and let her know what they are, and I can take those from Melody and return those out to Mel or to Michael or whomever the right person would be, so we can still work on answering those questions that didn't get answered. And then if you would please do the evaluation. I think that is critical on our part to know how we did. Did we sway you one way or the other? Pique some interest. Melanie's hoping so. Probably too. And what in the future would you like to see us do besides sing and dance? We won't do that. I would say, because I've gotten to know these departments much better over the last 9 months, that one of the things that I am most impressed with, not uniquely to these departments, but they are very good. They work together in a collaboration with all the different people from lab, the physicians, the nursing, RT. It is a group effort, and they rely on each other. They lift each other up. They support each other, and that's how some of this, they just do that because they love each other. They've become very cohesive as a group, and they just love and support each other, and that's how we're all going to get through this. That, and like Mel said, social distancing, and keeping your hands clean, washing them frequently, wearing a mask. And if you are capable and of the right age and are interested when the vaccine comes out, please, please, please consider that. Mel and I are up to date. We got our second one, and we both survived. It was not bad at all. I'm not sure about the guy behind the camera. Scott's gotten his, Michael's gotten his too. That's how we're going to turn the tide on this in a lot of ways. So consider it if you can, and do what you can. So thank you so much. I look forward to the evaluations and any further questions.
Thank you. Thank you guys so much.
Yeah.
I appreciate it.
Thank you. It's a pleasure.
Bye.
Bye-bye.
Bye. Scott, thank you.
Bye.
Bye.